Welcome to the HealthLeaders Exchange podcast. I'm Abby with the HealthLeaders Exchange team. I will have my guest introduce himself, and we are talking about payer compliance today. So it's a big topic, and let's get into it.
Well, thanks for having me, Abby. My name is Derek Dudley. I'm the AVP of Revenue Cycle Operations with Wellstar in Atlanta.
Awesome. Well, so like I said, this is a big one, and it's only getting worse. By the day, we hear it from all of our members. So let's start with the good. So what are some strategies you are using to help keep a good relationship with payers in your area? Is there anything you can pass along to our exchange community?
That's the answer is no, really.
Yeah.
We do JOCs where we try and have these kind of collegial or collaborative relationships. I was at HFMA's Southeastern Summit event not too long ago, actually yesterday, and they talked about this question came up on a CFO panel.
Right.
And one of the CFOs said, the house always wins. That's where the payers are. They hold a lot of the power. They can take their ball and go home, especially in a city like Atlanta where there's 4 or 5 other systems competing for that book of business. We're really beggars and not choosers. So it's hard to have that work together kind of relationship. We're trying though, and we all want to reach out to our payer partners and ask, how can we be better partners for you? And then in turn, we want them to ask, how can they be better partners for us? We're working towards that, but we're not there yet.
Yeah, I like that partner kind of dynamic because it also puts the ball in their court, maybe, to make a suggestion of what you could or could not be doing better. But it at least kind of emphasizes that partnership that you ultimately have, because it is a partnership in healthcare.
It's a little out of whack right now, though.
Yeah.
We're struggling, and Wellstar is a successful system, but comparatively, we're not having record quarter after record quarter. Our margins are fairly thin.
Yeah.
So, there's going to be this kind of reckoning at some point. They're dipping their toes in the provider spaces. Providers are working on providing insurance in their markets. There will come a time when, we all kind of don't get along anymore, unfortunately. So we're trying to find a better way before we get to that.
Sure. So the cost of prior authorization went up by more than half in 2022. I'm sure that sounds familiar to you.
It does.
Yeah. So, yes, you're seeing that in your area. Are you trying any different strategies maybe that you haven't in the past to kind of combat this?
For sure. We just actually implemented a strategy where we'll have a coder work kind of almost in the surgery suite or right outside the surgery suite. And anything that was performed, we want to validate against the auth. So did we perform what we authorized? And if we didn't, then we'll do same day authorization. So we'll act instantly to go out and get the authorization on the procedure that was actually performed.
Yeah.
That's small efforts. We're really working on cleaning up what we actually authorize from that. So what we're seeing is the provider will authorize and order something that is not exact enough.
Sure.
And so we get the wrong authorization.
Yeah.
So we're trying to kind of dial that in based on feedback from this coder position. So that's worked well. We also have a lot of different authorization initiatives where we're trying to educate the clinical staff on the requirements of a per payer kind of approach.
Yeah.
That's hard though. There's so many different payer variations, and the clinical staff is let's just keep it moving. On the billing side, we're like, hold on, we're not getting paid.
Right. And it's funny you actually bring that up. We at our CMO exchange this past year, they're actually bringing that up too. So they're kind of recognizing the issue as well and trying to find a middle ground with their revenue cycle kind of community within their health systems to make it better.
Well, and we're doing a lot of that even with clinical leadership, right? So we're doing service line denial education to the provider, to the department, to the location even. So we're really dialing it in so they know where we're leaking revenue.
Right. Absolutely.
Education. Yeah.
If you can get it across the whole organization, it makes the fight a little bit easier.
Everybody pulling on the same end of the rope.
Yes, absolutely. So kind of what are your plans to decrease these denials? Are you working with physicians? Sounds like yes. Yep. Leadership even higher than your physicians?
Yeah, we stood up a denials management committee, and it's kind of across the entire system. So not just Rev Cycle, we're pulling clinical leadership, HIM, everybody's kind of in and it has a seat at the table, and we're working together to find better ways to do this and prevent denials. Cleaning up some stuff we do to ourselves. We're ordering the wrong discharge or admitting after surgery, and we admit them into OBS instead of inpatient, or we admit them inpatient instead of OBS, and we're getting denials because it doesn't meet medical necessity.
Right.
So we're changing the surgical order sets. that present in Epic. We're an Epic shop. So some of these things present, or some of these things are hidden in the background. So we're just bringing them up to the front so the providers have appropriate choices.
Yeah.
So just working on cleaning things up a little bit.
Yeah, definitely. And so what do these conversations kind of look like one-to-one? So you're talking to a physician. How do you kind of approach that conversation with them of, yes, we know that you are doing your job, but if we take these steps, we could all kind of make it better?
It's changing. Providers are evolving, and I think that they're more interested in the business side of the business also,
Definitely.
right? So if we're doing the work, how do we make sure that we're compensated appropriately?
Sure, because it comes down to them as well.
So we talk about opportunities where we're seeing denials or where we're seeing payer pushback, or these are considered non-covered codes, or just educating them on that, changing the way they maybe interact with our EMR and how our EMR interacts with the billing system. That's a great way to bring them into the conversation. This is what you did. This is what comes out the other end. And if we continue to do that, we may not be able to provide this service going forward. So kind of putting it in context for them.
Yeah, I like, kind of showing them the whole perspective. So you do this, it's mostly right, but if you, do this one more step, then we get all of it kind of captured.
Well, and also even in their documentation, we have a certain population base that maybe at some facilities is sicker than other facilities. And it's geography, it's demographic, it's all sort of things, right? But if we fail to document the severity of the illnesses that the patients are presenting with, we don't receive appropriate compensation for the care we're providing.
Right.
And just really driving home the reason for the why, and not just treating what they're presenting for, but really treating the patient as a whole.
Absolutely. Awesome. Well, lots more conversations like this to have at our exchange. We're here this week in Carlsbad for our Revenue Cycle Exchange. If you want more information on future exchanges for more conversations like this with Derek, check the description below. Thank you, Derek.
Thank you for having me, Abby.
Yay. Thank you, Derek.
You're welcome.
Thank you for being flexible.
Of course.